everyone. I am Dr. Jigisha Pujara, working as a professor in Department of Cardiac Anesthesia at UNMICRC Institute of Cardiology and Research Center, which is affiliated with Bijay Medical College, Ahmedabad, Gujarat. Today I am going to present about assessment of the right ventricular function by transesophageal echocardiography. Recent studies emphasize the prognostic significance of RV dysfunction in various perioperative settings, leading to a closer examination of the so-called neglected ventricle. Echocardiographic challenges of the right ventricle are non-geometric complex shape precludes the characterization using the simple formula, so segmentation is not standardized. Thin wall and extensive trabeculations interfere with the assessment and with the endocardial tracing and with evaluating the wall thickness. Systolic excursions smaller than in the LV hinder the distinction of normal from the abnormal wall movement. For standard esophageal views, RV is in far field and has an oblique orientation. So assessment of the RV size and function requires multiple echocardiographic views and the techniques. Goals and objectives of these are anatomy and the function of the right ventricle, apply the technique for assessment of the right ventricular function, explore the echocardiographic views useful in the assessment of the RV, identify normal and the abnormal echocardiographic appearance of the right heart structure. Structure and function of the RV. RV is asymmetric complex chamber. It is a crescent shape in short axis cross-sectional area comprised of the inflow tract and the outflow tract. Inflow tract consists of, it begins at the tricuspid valve located postero-inferiorly, while trabeculae corneae and the muscle bundles line RV inflow chamber, which makes delineation of the echocardiographic border difficult. Outflow tract is infundibulous, its smooth wall positioned anterosuperiorly and leads to the pulmonic valve and the pulmonary artery. An encircling muscle ring separates inflow and outflow of the RV and is composed of four muscular bands: parietal bands, supraventricular band is a crista supraventricularis, septal band and the moderator band. You can see these in this figure. Moderator band extends from lower ventricular septum to the RV free wall and may be mistaken for the mass or the thrombus. RV medial wall formed by interventricular septum. It's shared with the left ventricle, and a lateral wall or the free wall. It is divided into basal, mid and the apical segments. Third wall of the RV is inferior wall adjacent to the diaphragm. Papillary muscles arises from the right ventricle wall and support the tricuspid valve via the chordae tendinis. RV systolic contraction has three components: longitudinal shortening caused by the papillary muscle and the longitudinal fibers in the free wall, increased rightward septal curvature caused by the LV contraction, bellows-like movement of the right ventricle lateral wall towards the interventricular septum caused by the contraction of the circular fibers in the right ventricular free wall. Longitudinal shortening is the major contributor of the RV ejection. Effect of the RV afterload on the qualitative assessment of the right ventricular systolic function. Thin walled RV is a volume pumping chamber, so its ejection fraction is extremely sensitive to acute increase in the PA pressure, in contrast to the pressure pumping LV chamber, which is less influenced by the afterload. T imaging of the RV. There are main four views which are very useful for assessment of the right ventricle are mid-esophageal four-chamber view, mid-esophageal right ventricular inflow-outflow view, transgastric mid-short axis view and the transgastric RV inflow view. Mid-esophageal four-chamber view, single most useful view for the assessing the overall RV anatomy and the global function, evaluation of the apex, mid and the basal segments of the RV. RV appears triangular, compared to the elliptical of the LV, and RV length extended only 2/3 of the LV length, and the left ventricle normally forms the cardiac apex. So when RV is normal, the left ventricle is forming the apex, and RV is not participating in the apex formation. Mid-esophageal right ventricular inflow-outflow view. It is also called the wraparound view. Right atrium, RA, RV and the PA encircle the aortic wall, and left atrium circumscribing 180 degree to 270 degrees arc. It's helpful in assessing motion of the diaphragmatic segment of the RV free wall and the RV infundibulum. It enables the quantitative Doppler equation of the tricuspid regurgitation jet, as jet is parallel to the ultrasound beam in this scan plane. You can see in this side figure this wraparound view or inflow outflow. Usually we get it at 70 degree of from the mid esophageal four chamber view, forward rotation of 70 degree. Transgastric mid-short axis view. This view is obtained in horizontal plane with the T probe inserted approximately 35 to 40 cm from the incisors with tip antiflex to achieve the true short axis view. Slight clockwise rightward probe rotation will center the RV image in the screen, and it allows the assessment of the RV free wall and ventricular septum. This reveals the crescent shape of the RV in the cross-sectional area. You can see these in a sideway echo image. Another is a transgastric RV inflow view. It provides long axis view of the RV similar to the transgastric two-chamber view of the LV. To acquire this view, one begins with the transgastric mid-short axis view of the RV and advance the multiplane angle to the approximately 90 degree or until the RA and RV are seen in the long axis with the RV inflow and tricuspid valve centered in the image. Alternatively, one develops the transgastric two-chamber view to the LA and LV and then rotate the probe clockwise or the rightward until two right-sided chambers are displayed. Inferior or a diaphragmatic aspect of the RV free wall seen in the neofield, which while anterior segment are seen in the far field. Here you can see this in the rightward figure. Supplementary views are mid-esophageal long axis view. It includes the portion of the RVOT and often pulmonary valve seen to the right of the aortic valve. Here you can see in the echo image the same transgastric inflow-outflow view. It's similar to the mid-esophageal RV inflow-outflow view and include the RA, RV, PA and both tricuspid and the pulmonary valve. This view acquired beginning with the multiplane angle to the approximately 110 to 140 degree and then rotating the TE probe slightly clockwise or the rightward. Here you can see wraparound like the same as the wraparound view of the inflow-outflow view of mid-esophageal. Here in the transgastric midway you can see at around 130 degree angle this same view mirror image. Deep transgastric RV apical view, image similar to deep transgastric long axis view but focus instead on the RV tricuspid valve and the RA. This view acquired by slightly clockwise or rightward rotation of the probe from deep transgastric long axis view. Here in the image you can see the RA tricuspid valve, RV and here LA and the LV. Mid-esophageal four-chamber view, this picture showing the RV in the mid-esophageal four-chamber view. And this is inflow-outflow view. Right ventricular hypertrophy, it results from the pressure overload of the ventricle caused by pulmonic valve stenosis and pulmonary hypertension, either primary or the secondary to other causes like LV failure, mitral stenosis, amyloidosis, endocardial fibroelastosis, etc. Right ventricular free wall thickness measures to determine the hypertrophy. Normal thickness is less than the half of the LV thickness, wall thickness, and the RV hypertrophy diagnosed when RV wall thickness in end diastole exceeds the 5 mm. Here you can see this thickness. RV dilatation, it occurs with the RV volume overload. Here RV forms the cardiac apex in the mid-esophageal four-chamber view. You can see in this echo image, RV is participating in the formation of the apex. Often at the 5 to 25 degree of the multiplane angle rotation, we can get this. With moderate dilatation, RV area equals to the LV area, and with the severe RV dilatation, RV cross sectional area exceeds that of the left ventricle. RV shape changes from the triangular to the spherical. Quantitative measurement of the RV, mid-esophageal four-chamber view. Left side you can see mid-esophageal four-chamber view, mid-short axis perpendicular to the long axis of the RV at an end diastole. Here you can see mid-basal short axis and long axis. We can take the diameters. And on the image on the right side, mid-esophageal inflow-outflow view, RV outflow tract and the pulmonary artery dimension at the end diastole. Here you can measure the RVOT and here you can measure the pulmonary artery. Here this table showing the measurement of the RV dimension in mid-esophageal four-chamber view and mid-esophageal inflow-outflow view with normal values and mild, moderate and severe RV dilatation. There are various values. One must remember these values. RV overload and ventricular septum. Septum motion determined by pattern of the myocardial depolarization, state of muscular contracture and the pressure gradient between the RV and LV. Normally, LV pressure exceeds RV pressure throughout the cardiac cycle and maintains the convex curvature towards the RV during the systole and diastole. So, LV is spherical. Is RV hypertrophied? IVS, this septum flattens, results in a D-shaped rather than the round LV cavity on the transgastric short axis view, maximum at end systole and early diastole when intracavitary pressure in the RV is at peak. Chronic RV pressure overload causes RV dilatation, tricuspid regurgitation from the annular dilatation and the RV hypertrophy. RV volume overload, it causes septal flattening at end diastole at time of the maximum ventricular filling and distension. This leftward movement reverses during the ventricular ejection as the RV empties, causes the paradoxical septal motion towards the RV cavity during the RV systole. Similar septal motion occurs during ventricular pacing owing to the delayed activation of the left ventricle during the right ventricular pacing. So septal bounce will be occur in this. RV systolic function, quantitative and the regional assessment. It includes chamber size, wall thickness, RV systolic wall excursion and the extent of the systolic obliteration of the RV cavity. Occlusion of the right coronary artery or one of its acute marginal branches, conus or the conus branch of the LAD can cause the regional RV dysfunction. Cardiac surgery itself causes regional RV dysfunction. Inadequate cardioplegia or for the right ventricular protection when retrograde cardioplegia is employed, and this anteriorly located right ventricle more prone for the ambient warming from the surgical light. So anterior wall is having the more chance of the inadequate myocardial protection. Anterior non-dependent location of the RCA, saphenous vein bypass graft, make this favored site for the coronary air or the atheromatous embolization. Inferior wall LVMI accompanies the RV infarction due to the common blood supply from the RCA. Right ventricular MI causes the RA enlargement, RV dilatation, tricuspid regurgitation, and the paradoxical ventricular septal motion. If patent foramen oval is present or the ASD is present in the patient, it will cause this increase in the RA pressure may lead to the this RV dysfunction causes increase in the RA pressure by the tricuspid regurgitation, and there is paradoxical movement of the blood from right to left, and it can cause the shunting of the blood from right to left, and some hypoxemia cyanosis can occur in the severe RV dysfunction patient. And of course there is a paradoxical thrombus can cause the stroke in the patient. RV global systolic function, quantitative echocardiography, measurement of the RV volume and ejection fraction. Simple ejection phase index is the one-dimensional shortening fraction which can be calculated in either short or the long axis. Planimetry measurements in the mid-esophageal four-chamber view, right ventricular functional area change (FSE) can be calculated. FSE is equal to end diastolic area minus end systolic area divided by end diastolic area multiplied by the 100. Normal FSE is 32 to 60%. In mild RV dysfunction, FSE is 25 to 31%. In moderate RV dysfunction, FSE is 18 to 24%. And in the severe cases, it's less than 18%. In CABG, if FSE is less than 35%, it suggests the worse early and the late post-operative outcome. Here you can see in the echo image on the left side when we trace the RV from inside edge, it is end diastolic area and here in the right side image it is end systolic area we can frame out. RV ejection fraction, complexity and potential inaccuracy of the method, quantitative assessment of the RV volume rarely performed in the clinical T practice. Modified Simpson method can be used for calculation of the right ventricular ejection fraction. Normal value is 45 to 60%. Three-dimensional echocardiography will also help for the more accurate measurement of the RV size. Other more accurate means of the quantifying the RV function are contraction of the longitudinal muscle fiber causing long axis shortening, motion of the tricuspid annulus towards the RV apex, tricuspid annular plane systolic excursion, that is TAPSE. It is described long axis systolic excursion of the lateral aspect of the tricuspid annulus, useful in as an additional measure for the global RV systolic function, is commonly used intraoperatively and the postoperatively in the ICU. TAPSE measures either in the mid-esophageal four-chamber view or the transgastric inflow-outflow view. This view is preferable because it's due to the parallel movement of the ultrasound beam. This view is commonly utilized. Normal TAPSE is 15 to 20 mm towards the cardiac apex, and decrease in the TAPSE is poor prognostic for the acute MI. TAPSE in mid-esophageal four-chamber view. TAPSE is the difference between the end diastolic length, that is here you can measure it as 8.9 cm roughly, and the end systolic value 6.8. Difference between these two will give the value of the TAPSE. Easy to acquire image in the intraoperative setup, even in the pediatric cases also. The same here in the diastole and systole you can see. TAPSE in transgastric inflow-outflow view using the M mode on lateral tricuspid annulus. Thin dashed white line here you can see it's delineate the moment of leading edge of the tricuspid annulus towards the transducer. Tricuspid annular velocity using the tissue Doppler with the sample volume located on the lateral tricuspid leaflet attached to the RV free wall. In patient with the tricuspid regurgitation, acceleration of the regurgitant jet reflects rate of the increase in the RV pressure during the right ventricular systole. The index called dp by dt can be calculated by measuring time interval between jet velocity of 1 meter per second corresponding to the ventricular atrial pressure gradient of 4 mm Hg and 3 meter per second corresponding to the pressure gradient of 36 mm Hg. Here at 1 and at 3 we can measure the pressure. RV dp by dt is the instantaneous rate of RV pressure rise during the early systole and is a surrogate marker for the RV contractility. The dp by dt calculated by dividing this pressure difference 36 minus 4 is equal to 32 by the time intervals in the seconds between these 2 points on the spectral Doppler envelope. Normal value for RV dp by dt is over the 400 mm Hg per second. This calculation matches with the value derived from the invasive cardiac catheterization and independent of the RA pressure, more sensitive to the preload changes and less sensitive to the afterload changes. Another is the we can perform the myocardial performance index, that is MPI. RV global function is assessed by MPI is the ratio of time spending isoelectricity divided by time spending the ejection. Sum of two isovolumic intervals, isovolumic contraction plus isovolumic relaxation divided by the isovolumic time, that is ET. Here you can see ICT and IRT, and this is ejection phase ET. For RV, ejection time is measured using the Doppler interrogation of the pulmonary artery flow, while isovolumic time are calculated by subtracting the ET from the total duration of the RV systole. Systolic duration can either be measured as a duration of the tricuspid regurgitation jet or the interval between the end of A wave and the start of the E wave on tricuspid inflow spectral Doppler tracing, and ET measured in pulmonary outflow Doppler. Here systolic duration of 412 millisecond and the this ET ejection time is 264 milliseconds. So MPI is 412 minus 264 divided by 264 is equal to 0.56. Here in echo image on left side spectral Doppler trace of the tricuspid inflow, and here on the right side pulmonary outflow in the deep transgastric view. MPI is a composite index of the both systolic and the diastolic function. It's relatively independent of the heart rate, afterload and the preload. Normal values of the RV range between 0.2 and 0.4. Value more than 0.5 is high predictive of the hemodynamic instability and mortality after the cardiac surgery. Advantages of the MPI is it's simple to estimate, reproducible and not affected by the geometry, and it will assess the global function of the right ventricle. MPI tie index inverse relation with the global RV function. Increasing value indicate worse RV function. MPI is equal to TI VCT plus TI VRT divided by TET. Here in this you can see that TI VCT, TI VRT, TET and E prime, A prime and the S prime. RV function hemodynamic assessment. Cardiac output measured across the RVOT value well correlate with the thermodilation cardiac output values in the patient without significant TR. For this pulse wave sample volume placed just before the pulmonary valve in transgastric RV inflow outflow view, where RVOT diameter can also be measured. Stroke volume is calculated as RVOT cross-sectional area. It is 0.7 times the diameter squared multiplied by the RVOT velocity time integral VTI. Here in the echo image you can see the RVOT VTI. In patient with the TR, continuous wave Doppler used to estimate RV systolic function, RV systolic pressure with good Doppler alignment. Measurement of the peak velocity of the tricuspid regurgitation jet calculates the pressure gradient between the RV and the RA, which when added to the RA pressure provide the estimate of the RV systolic pressure. This is very commonly used intraoperatively. We can just put the cursor over the tricuspid valve and take the measurement, and it is at 20 to 30 degree of the multiplane angle. You can achieve this view with this image, with the color tissue with the Doppler image. And measurement of the peak velocity of the tricuspid regurgitation jet can be calculated. In absence of the RV outflow obstruction, RV systolic pressure provides good estimate of the PA systolic pressure. RA pressure. Estimate of the RA pressure can be gleaned from the examination of the IVC. Respiratory variation in the IVC becomes smaller during the inspiration in the spontaneously breathing patient. IVC diameter measured 1 to 2 cm below the atrial cable junction as viewed from the transgastric approach with the probe rotated towards the right. The combination of the maximal IVC diameter during the quiet breathing normal value is 17 to 21 mm, and the decrease in the diameter and the response to the forced sniff maneuver collapsibility index normal it is 35 to 55% provide the estimate of the RA pressure. If IVC diameter less than 20 and IVC collapsibility index more than 55, the estimate RA pressure between 0 to 5. If this IVC diameter less than 20 mm and the IVC collapsibility index is 35 to 55, then roughly RA pressure is 0 to 10. If IVC diameter more than 20 with collapsibility index more than 35, this estimate RA pressure will be 10 to 15, and if it is more than 20 IVC diameter, then IVC collapsibility index, if less than 35, then RA pressure is between 10 to 20. In mechanically ventilated patient, IVC diameter increase during the inspiration. Increase in the diameter if more than 12% predicts an increase in the cardiac output in response to the volume loading. Right ventricular diastolic function, inflow velocity pattern across the tricuspid valve used to assess the E and A velocities. Normal peak E velocities is 45 plus or minus 7.5 cm per second, while peak E wave velocity 30 plus or minus 8.1 cm per second. Impaired relaxation of the right ventricle results in the decrease in the E wave and tall A wave. Restrictive RV physiology results in tall E wave and small A wave. Another is the hepatic vein flow pattern. Normally it has 3 to 4 phasic components. The decline in RA pressure during the systole results in an initial forward flow towards the RA and is termed as the S or the systolic wave. These pressure changes results from atrial relaxation, and the apical movement of the tricuspid valve during the RV systole corresponds to the X descent in the atrial pressure. A fall in atrial pressure during the diastole from early ventricular filling also results in forward cable flow D wave, and that corresponds to the Y descent in the atrial pressure. Two small retrograde waves can be seen, one of the which results in end diastolic atrial contraction, that is A wave, and the other small retrograde wave, that is V wave, appear at end systole prior to the Y descent in the RA pressure that drives the forward diastolic hepatic vein flow wave. Impaired RV systolic function causes blunting of the S wave and augmentation of the T wave, which requires vasoactive drug support. Third modality to assess the RV diastolic function is tricuspid annular Doppler analysis. In tissue Doppler imaging of the RV free wall, E by A velocity ratio decreases with the age. Thank you. That's all about the right ventricular function assessment by the transesophageal echocardiography.